with the mics. I'm not quite sure how we're going to do this, but we will try. My name's Jane Clegg. I'm the Director of Nursing for NHS England in South London, and one of my responsibilities, I work in Caroline's team, is for the out-of-hospital nursing. So I'm really pleased to be here today. I stood up earlier and talked about our inspiration landscape, which we'll come back to later. I didn't introduce myself, so there you are. You know who I am now. And now it's your chance to ask questions of our presenters thus far. You've heard of a range of things this morning. Caroline's story about why she's here and why she feels so strongly about the value of community and general practice nursing. Pete's ideas for shirtless and disruptive change with his S-curve on the chart over there. And then Jonathan's views about community nursing as an outsider. Slightly less of an outsider than he was 3 odd years ago, but an interesting view on what's important and where we need to be going for the benefit of patients and the people we see. So I'm going to open up to the audience now for your questions of our panellists. There will be a mic. I think it's this one here. Oh, okay. So I've got one here. Is there anybody else who's got a question so we can line them up and make it seamless? There's one over here. Okay, and then there's a third there. That's great. So, if you can introduce yourself and say who you are and why you're here, just very briefly, and then address our panel.
My name's Maurice Hoffman, and I live in Brent. I suppose I'll be called a patient rep, the honorary patient here. Now, I'll ask Jonathan, what happens, for instance, if a district nurse turns up and finds the house freezing cold, or the patient malnourished? You know, let's move beyond the clinical into what might be called well-being. So could we have some response of that, please?
And this is where my outsiderness doesn't really help me. I don't know what the nurse, she'd probably pass it on to social care and housing and so on and so forth. What I think should happen, to answer your question, is for us to have much more pool budgets. So we work with an international company which pools the budget. So in a precise example like that, they've moved people out of their housing and they've moved them into different accommodation, which is warm and where they get properly fed, because they have, firstly, it's the right thing to do, and secondly, in the long term, it's much cheaper. So at the moment, I think we would probably fail that patient because we don't have the control we need to provide a proper solution for them. Or there's a chance that we'd fail them because lots of different agencies are responsible for looking after them. So I would be worried on behalf of that patient in the current setup.
Great.
Yes.
We've had that situation very recently where our nurses have gone into a home where a married couple, both of them with dementia, were very unwell. They had no food in their house. They were dirty. The nurses went in to give insulin, and the husband and wife hadn't eaten for quite a few days. They had no food in their house, and the nurse on a Friday evening went down to Waitrose, got food, brought it back, cooked for those clients, and got a social care package in, and they now have a resident carer. So we absolutely would support those patients, as would any nurse that's sitting here. We wouldn't just leave them. It's not always easy, and that's where nursing shines through, when you can see the passion that a nurse has for her clients.
Thank you. Right, I think we had a question here. Do you want to indicate? Yes, there. Thanks.
Okay, hi, my name's Shade, and I'm from the Integrated Community Response Team, Rapid Response in HCH, Hounslow and Richmond. My question is to Jonathan. The leg club, I'm interested in how does that work? Because do you actually get patients taken to somewhere? Is there a criteria? Because a lot of these lonely old patients or older patients can't get out of the house, and that's a big issue. So this club that you have, do you rent a premises? Is there transport to take these patients? How does it work?
The best person to answer that question is actually Rachel. As Amanda answered the last question much better than me, I'm going to let Rachel answer that one.
Our leg, it's on, yeah.
Do you say who you are?
Rachel Street, Assistant Director of Operations at Bromley Healthcare. Our leg club runs once a week from a church hall, which we hire the church hall. There's a committee of volunteers that do the fundraising to pay for the rent of that hall. And they also provide the tea and the coffee and the entertainment. And then we provide the nursing staff who go in there and treat the patient's legs. In terms of criteria, it's just somebody with a Bromley GP that's got a lower leg wound. In terms of transport, one of the things we'd love to be able to do is provide transport so that we can get more of our patients into the leg club. But at the moment, the patients do depend on relatives or carers, or they can walk if it's close enough to them. But we are looking at working with the voluntary sector to increase the accessibility of the service for those that do find it difficult to get out of the house.
That's great. Can I ask you, if you wouldn't mind completing one of our forms and perhaps putting it on our inspiration landscape? Just it sounds like people are interested in that.
Jane, I've got a question for Rachel, actually. Rachel, can you tell a little bit about who came up with that idea and how you encourage people to come on board and then follow through with that process?
Not entirely, because it started before I joined Bromley Healthcare, unfortunately, but it is part of the Lindsay Leg Club Foundation. And there are a number of similar leg clubs run in other areas. I know, for example, there's one in Southend, there's a couple in Essex. Jonathan might be aware of who started it from Bromley Healthcare's side.
The example of the leg club is a very interesting idea, which I was sort of talking to the Birdsong people about when you encourage people to do things and when you force people to do things. So the leg club and that bit of electrical kit, we basically forced people to try. They didn't really want to try it, but we kind of said, well, you're going to try it. And it produced obviously very decent benefits. So the idea, it was the nursing director's friends run one in a different part of the country. And when we were talking about the lonely old women, it was one of the things that came up, and we just said, well, we're going to try it. So it was a bit of a top-down thing, the leg club.
Great, thank you. Okay, yes.
My name's Debbie Brown, I'm from Lewisham, and I'm a Queen's nurse. And I just wanted to ask Jonathan a question, please. Really interested in your piece of kit that you've got. And I just wondered, I saw it had EMIS on it. Does that mean when the nurses put on something on the template on a read code, it goes automatically into the GP's system?
We've developed EMIS as a parallel system. So if you're a GP, you can basically have the systems sitting next to each other on the screen. They're both EMIS web. We've got all of the information sharing set up. So if the GP wants to share information, they just have to click a button. What's different? Oh gosh, I've got feedback, it's hard. What's different I think, with ours from other community applications of EMIS is we've done all the read codes, so we've tried to make it as close to the GP's version of EMIS as possible.
But it's not the same read codes?
My understanding of read codes is that EMIS has a set of read codes and we choose the ones which are relevant. So one of the challenges we've got at the moment is there aren't enough read codes on EMIS for bladder and bowel. So we've had to ask EMIS to create some new read codes, but then you'd hope that our bladder and bowel read codes would be the same as the GP ones.
So that's a really good move forward.
Is it something again for our inspiration wall?
Yes,
so
it's one data entering point rather than entering it on the patient's notes, coming back entering it on Rio, then somehow getting it to the GP surgery, then we've got to input it in a GP surgery, then putting the data on there. So that's time. So yeah, if that works, fantastic.
Yeah, it gets rid of all of that.
Yeah. On a point, we've got one of our workshops this afternoon is around technology, and I noticed there weren't that many people signed up for it, but it's clear, at least Debbie's, and probably more of you have recognised that would be really good. So perhaps cross out your leadership workshop and add your name to the IT. Right, now, where were we? We had someone here, I think.
Peter Rolland from Health Education North Central East London. And I was interested in the two presentations being quite contrary in some ways. So I was particularly interested in Pete's presentation about disruptive leadership and what we need to do to allow nuts to develop. But we work in a very conventional system and a very political system. So I wonder whether that actually needs to be written into job descriptions. You will be a maverick. How do we deal with the contrast between fitting into a system and creating innovation?
Yeah, great. It's a great question. I'm currently working with Helen Bevan and Alistair McClellan over at HSJ. We're running a national conversation about it's called the Change Challenge. Some of you may have seen it in Nursing Times as well as behind this too. And of the sort of 8,000 or 9,000 contributions we've had to this process so far, this question's come up. You know, and actually what we see is there's a kind of almost need to be an ambidextrous leader. In one hand, you're kind of cranking the normal machine, but in the other hand, you've got to be willing to rock the boat. And equally, we want our staff to have that freedom too. So the question then comes is how do you give people that freedom, that autonomy to do that? And it's very difficult. You're itching to say something. Go on.
Does that not put them in a very vulnerable position?
Yeah. So the question, in case you didn't hear, was does it not put those people in a vulnerable position so they can facilitate that change? I was sat with a chief exec who will remain nameless the other day, who just got back from the Trust Development Authority. I said, how did it go? He said, well, I've just had my bottom smacked for 2 hours and now I've got to go and be an empowering leader to my staff. And that's the reality of it. He didn't get that nurturing that he needs, but he tries really hard to provide that nurturing to his nursing staff. And I think the key thing comes down to respecting people and having compassion for your staff, and believing that they know what's got to happen because they're at the front line. And if you empower them to make that change, they can. It's challenging though.
Right, more questions. Now, I was told there was, right, someone over there, and then the colleague in the reddish jumper.
Thanks. I'm Paula McLaren. I'm the nurse lead for Barnet's Community Education Provider Network. And I'm also leading a project in a deprived part of northwest London to promote well-being, and some of the conversation, it's more a comment than a question, some of the conversation, particularly from the patient, was about well-being and supporting patients within our communities. And our project has been, we're working with a group of 6 GPs in the local area and we're working with community coordinators, working with the community and voluntary sector to provide resources and information and navigate patients, develop volunteers, healthcare champions to support initiatives like your leg ulcer clinic. And I think as general practice nurses, we have to think about the bigger picture now. We have to begin to focus on well-being, think about new ways of working to support patients, not only with long-term conditions, but keeping them well, looking at their social, psychological needs. You know, do they speak English? Do they live alone? Is their house cold? We've set up drop-in sessions with public health in Barnet, in our local church, for the elderly population who can't keep their houses warm, don't have any food to eat. So all of those things, a lot of what we're trying to do is reliant on volunteers, but there's a huge amount of resource out there that, you know, I'm also a practice nurse. Within my surgery, we have no idea about the services, community and voluntary organisations that are out there and willing to support and help people within our communities.
Thank you. That's great. Right, we've just got time for a couple more, so I think one here and then one behind.
My name is Gil Smith and I'm a primary care nursing development lead for Camden CCG. I just want to pick up on the empowering staff that my colleague talked about and ask a question to you, Jonathan, about the little things that the nurses report to you. How do you ensure that your nurses know, or your community staff know, that they've been listened to? Because I think part of empowering people is ensuring that they know that they've been listened to.
That is a very good question and a very challenging task. I think it just requires elbow grease, like spending a lot of time spending a lot of time in nurses actually just trying to fix the problems. What the organisational challenge it threw out for us was that our support functions like HR and estates weren't nearly responsive enough. So we had a lot of work to try and do to make HR realise it was actually accountable to the nurses, that estates was accountable to the nurses. So it takes a lot of my time personally, and I spent 3 hours on Friday afternoon getting an earful on it, everything that's not working because we've got a terrible estate. And then you've actually got to change your whole organisation to try and make it realise that it's just there to try and help the nurses do their jobs. So it's a big effort.
I think it's great, though, that you're doing that. And I wish more people did that. Because for me, that's a stepping stone to empowerment, or one of them. Yeah.
Thank you. Right, final question, and it's just behind.
Thank you. I'm Angela Banner. I live in the London Borough of Redbridge, and listening to the talk, the part that interested me most was the Leg and Ulcer Club. I could name half a dozen people who would today benefit from that. In our borough, I don't know of anything, any other animal that is similar to that. How would I find out?
Very good question. I think your providers have a website. There might be something on there if they're providing that. But it's a good question, and it draws me back again to our Inspiration Landscape, which is open for anybody to put up a project, an initiative to share. But I think locally publicising is a big issue, and we've already heard of a colleague over there saying that that the resources in the voluntary sector are not well understood by people in the health sector. So I think sharing that information is a really important aspect of providing services, joined up services, and making the most of all our community assets.
Jane, can
yes,
I just,
Caroline?
Great. I just wanted to add something about who are the commissioners in the audience. I've challenged to all of you to go away and think about how you are working out what services you should be doing, because I always think what we do is we do what we're used to, which is to provide services in a traditional way. What I've learned through some of the journey I've been on is that actually, particularly working with housing associations, that if you go to people and ask them, say, this is the outcome we want, go away and come up with a different model, you'll find your providers, your mainstream providers will probably go into partnership with some of your local community organisations and come up with something quite different. So I just ask you to think as commissioners of the art of the possible and not just always commissioning what you've always commissioned as the solution. I think that's a really good example of what might need to be different.
Yeah, good point. Okay, thank you for your attention and your questions. We're going to head for a break now. We've got coffee, and you're in the marketplace until past. If you can come back here sharp, because you're going to go back to some of the work you did earlier on the tables, and then come 12 o'clock, we've got the change hour with Helen Bevan, already promoted by Pete, so your opportunity to think about things you want to change. Thank you.